Good morning, everyone. Case number 4, 8 years female admitted with pneumonia like symptoms. This is the microphotograph of RBC's morphology, normocytic normochromic. You can see few bite cells, sickle cells are seen. Among WBC, a neutrophil is seen and also platelets are seen. Diagnosis is sickle cell anemia on peripheral smear. Genetics of sickle cell. Sickle cell is an autosomal recessive disease. Therefore, the child can only get sickle cell if both the parents are carriers. Not only if one is and the other is normal, they have 20%, 25% chance of getting it if both are carriers. Molecular pathology of sickle cell disease. The mutation is at the 6th codon of beta globin chain, where glutamic acid is replaced by valine. The same mutation is found in all the sickle cell beta genes around the world. Red cells containing HbS acquire the sickle shaped deformity on deoxygenation because of the intracellular polymerization of hemoglobin. This phenomenon may be monitored directly with the light and scanning electron microscopy and indirectly by measuring changes in viscosity or filtrability. Electron microphotographs demonstrate the filaments in parallel array, some of which extend into the protuberance of the sickle cells. Early symptoms and complication typically appear in the infant's first year. First symptom like dactylitis and fever at the age of 6 months to 2 years, pain in the chest, abdomen, limbs, joints, enlargement of heart, liver, spleen, nosebleeds, frequent upper respiratory infections. Over time, sickle cell sufferers can experience damage to organs such as liver, lung, kidneys, heart, and spleen, and it can also result in death. The laboratory features red blood cells in sickle cell anemia. A moderately severe normocytic normochromic anemia manifests by 3 months of age and persists throughout the life. The average hemoglobin concentration 8 gram per dl. Mean hemoglobin levels vary with gender and with age, higher in adult men compared with women, and higher in males between ages of 20 to 39 years. In adult hemoglobin sickle cell chain, the mean MCV is approximately 90, MCHC is 34 gram per deciliter. The MCV and MCHC lower in the patients with concurrent thalassemia minor and in iron deficiency. Blood smears contain variable number of sickled forms, target cell, cigar-shaped cells, ovalocytes. Morphologic features of accelerated erythropoiesis, polychromatophilia, basophilic stippling, and homoblastosis are prominent. The mean reticulocyte count is approximately 10% with a range of 4 to 24%. Howell-Jolly bodies and Pappenheimer bodies reflect functional asplenia. Chronic hemolysis is responsible for elevated unconjugated bilirubin and heme proteins. The serum haptoglobin level is decreased. White blood cells. The white blood cell count is consistently elevated owing to an increase in the number of mature granulocytes, 12 to 15,000 with a range of 6 to 20,000. This increase is explained in a large extent by shift in the granulocytes from the marginated to the circulating compartments. Both total and segmented leukocyte numbers increase during vaso-occlusive crisis infections, but only in bacterial infections. Consistent increase can occur in non-segmented neutrophils. Platelets and coagulation. Increased platelet count reflecting reduced or absent splenic sequestration. Both platelets and megathrombocytes decrease during vaso-occlusive crisis. Platelet aggregation is decreased, likely result because of in vivo platelet activation. The contact factors decreased. Platelet 8 activity, fibrinogen concentration, and fibrinolactic activity is increased, reflect the vascular endothelial damage inflicted by sickling process and not primary perturbations responsible for the crisis. The sedimentation rate consistently low even in presence of anemia, hyperfibrinogenemia, and active inflammation. The failure of sickle cells to undergo rouleau formation. The serum lactate dehydrogenase level increased because of hemolysis, increased further during vaso-occlusive episodes. The blood test, the sickling phenomena may be demonstrated by the thin wet film of a blood sealed with a petroleum jelly or paraffin wax mixture. If sickle hemoglobin is present, the red cell lose their smooth counter shape and become sickled. This process may take up to 12 hours in sickle trait, whereas changes are apparent in homozygotes and compound in heterozygotes after 1 hour at 37 degrees centigrade. These changes can be hastened by the addition of reducing agent such as sodium dithionate. Solubility test. This test tells the decreased solubility of deoxy sickle hemoglobin forms the basis of tests in which blood is added to a buffered solution of a reducing agent such as sodium dithionate. HbS is insoluble and precipitates in solution, rendering it turbid, whereas solutions containing hemoglobins other than HbS remain clear. Hyperglobinemia and other sickling hemoglobinism cause false positive reactions, false negatives, addition to inadequate number of sickle cells. This is the test of solubility. Quantitation of HbA2 is performed by mini column chromatography or HPLC. Quantitation of HbF can be carried out by alkali denaturation HPLC or radioimmunodiffusion. The distribution of HbF in red cells may be analyzed by its resistance to acid elution and more precursorily by HbF cell specific antibodies that measure the number of F cells. The diagnosis of sickle cell anemia also can be done on electrophoretic and chromatographic separation of hemoglobins in the hemocylates prepared from the peripheral blood. The predominant hemoglobin will be S. HbF is present in varying concentration. HbA2 is normal. Electrophoresis uses the cellulose acetate and the alkaline buffer rapid, inexpensive, and effective in separation of normal hemoglobins from the common variants. Rare hemoglobin variants have an electrophoretic mobility identical to that of HbS on cellulose acetate. Main treatment methods include drug treatment, blood transfusion, blood and bone marrow cell transplantation, and gene therapy. Thank you.